Oh my God, this was a very incredible presentation. I thank you, and I thank you very much for your invitation. This is the hugest audience of my entire life. I will never reach again something like this. Is giving me breathless sensation. So, the question is, can a dermatologist practice without dermoscopy? I don't want to answer this question. I want you to answer this question. Can you practice without dermoscopy? Can you raise your hand if you can? Okay, a few. Okay, I have to convince you, especially these two guys in the front. So, who is not able to live without dermoscopy anymore? Can you raise your hand just to have an idea? Okay, okay. So, my job is really easy because I have to convince only a very minority of people. So, I was always, in my view, so people ask me frequently, how was your life before dermoscopy? And I can tell you, I have no idea. Yeah. No idea. I'm a X generation. Should I be an X generation? Yes. So as an X generation, I basically started using dermoscopy when I was like this. So I have really no idea how can I live without dermoscopy. Well, actually, at the time I was starting in the early 90s, we used this kind of stuff, a big machine like this. Nowadays, we use a very small instrument, much cheaper than in the past. But the point was, since I was starting using dermoscopy when I was basically doing my medical thesis, so I was still a student, I started basically learning dermoscopy before being able to make a diagnosis of tumors, of skin tumors, clinically. Okay, so I first started with dermoscopy, and then I learned the clinical way of diagnosing skin cancer. Okay, and then of course I understood very well that the more expert I was becoming in dermoscopy, the more expert was becoming also in the clinical recognition of skin cancer. So basically, clinical information, clinical recognition, and dermoscopy, they are always together. They are not fighting each other. They are always together. They are like a good couple, you know? We need the clinical information and dermoscopy to make a proper diagnosis of skin cancer. Okay. By the way, this was a very long way to go. When I started in the early 90s, these kind of professors were my professors, and, you know, they were looking at me, you know, laughing, you know, and saying, come on, dermoscopy. I mean, if you are a good clinician, you are able to diagnose skin cancer by the naked eye. You don't need an instrument. Of course, I agree 100%. In the great majority of cases, we are able to recognize clinically that this is a skin cancer, okay? So this is true for 70% of the melanomas we see in our practice. 70%, it's not 100%, okay? So we still need something to recognize 30% of the melanomas we see in our practice, meaning 1 out of 3, basically, okay? Let's make an example. This is a girl. She's 14. The lesion is located on the back. The mother of this little girl is saying that the lesion is congenital. So who is thinking that this is a congenital nevus? I mean, come on. This must be a congenital nevus. Okay, so who cares? Should we, okay, we do a follow-up, right? And we ask the patient coming back in maybe in 6 months if this is the way you manage congenital nevi. But if we use a little bit our dermatoscope, we immediately catch that there is something wrong here. No? There is this kind of bluish coloration, which is one of the most frequent dermoscopic features allowing us to think about melanoma. Okay, and this was the only reason why we excised this lesion. And of course, this is a congenital nevus, but it's a congenital nevus where a thin melanoma was starting to arise. Okay, so this is the reason why I think dermoscopy is not something we can decide yes or no to use it today, but it's something really helping us. And it became, in the last 30 years, it became it was starting like a second-level screening tool. Now it's a first-level screening tool, okay? If we like to increase our ability to recognize melanomas which are clinically looking benign, we have to use it as a first-level screening. Okay, but now let's go to the 3 facts, not more than 3 facts why I love dermoscopy. I cannot live without dermoscopy. Okay, first, basically we saw it already, increasing sensitivity, especially in general for skin cancer, but especially for melanoma, okay? Melanomas like this are basically not diagnosable if we use only the clinical eye, okay? But if we add our dermatoscope, there is no question that this lesion is becoming suspicious, and it's giving us the possibility to decide to excise it, okay? So melanoma, it's easy, you know? Melanoma is growing like this. We can diagnose it when it's large enough to become asymmetric, multicolored, irregular in shape, okay? But melanoma starts when it's a small, tiny macule, okay? And here where dermoscopy can be useful for us, okay? Another example, I mean, come on, no way. This must be just nothing. But if you look dermoscopically, you know, you think that this is a lesion you like to remove. And that's why we are not going to miss anymore this kind of melanomas. Okay. But the second point, which is even more important because it's affecting our daily life, it's the increased specificity. Okay? Meaning less lesions, less benign lesions we are going to remove unnecessarily. Okay? So for example, let's make an example. Here we have the amount of melanomas that we are going to see in US. Only in US this year, they are 100,000. Okay? You know what is the number needed to excise? This is a value, it's a measure. Number needed to excise means that if we are, let's say, expert clinicians, we are going to excise something like 30 benign lesions for one melanoma we are going to recognize, okay? So we have to excise some benign lesions in order to catch the melanoma. And usually we excise 30 benign lesions each melanoma we see. This means that we are going to excise something like 3 million benign lesions to catch these 100,000 melanomas. So here where dermoscopy is affecting really our practice every day, okay? So if we use dermoscopy, from 100 lesions that are suspicious enough clinically to be excised, we reduce to about 50%. So we reduce the unnecessary excision of about 50%, which is really changing our practice. Look at this lesion. I have to excise it. It's an ugly lesion. But what it is? What it is? It's a seborrheic keratosis, of course. Should we excise it? No, come on. We are confident. What about this lesion? It's ugly. I don't feel confident. And look at this one. Again, seborrheic keratosis. Seborrheic keratosis are the most common benign lesions of human being. Okay, so we see many, and we see many of these ugly lesions clinically. So that's why dermoscopy is impacting our life every day in this particular context. And I can give you more and more examples. An ugly one, seborrheic keratosis. Ugly, very ugly. Angiokeratoma. Oh, okay. And what about a patient like this? You know, and when my professors in the early 90s were saying, okay, come on, you don't need dermoscopy, clinical eye is the only thing you need. Okay, and what about this patient? How can you manage a patient like this without dermoscopy? Impossible nowadays, okay? The only way I know to manage this patient is to do something like this. It was proposed that you, okay, who cares? Let's remove the entire skin. Well, maybe the patient will not be so happy, So it's better to be a little bit more, let's say, specific. So the three rules we use today to manage this kind of patients is examine all the lesions, yeah? And then compare. So do your comparison, because usually nevi look the same in the same patient. Ugly nevi look the same ugly in the same patient, you know. So that's why the comparison is important. And then, of course, monitoring this kind of patients is important. So this is a sample of the lesions of this lady. Okay, they are all ugly, more or less, right? Okay, is there some of these lesions you like to remove now, today? Give me a number. 8. You said 8. You said 8. 12. Okay, 12. Okay. Who said 8? Who said 8? Wow. Okay, you're very good. We were not able to understand that 8 is the melanoma of this patient, but we catched it 3 months, 4 months later because we did monitoring. And when we monitor a lesion, when we monitor a melanoma, after 3, 4 months, very often you see already some little changes, like in the case like this, like in this melanoma. And that's why we were able to excise it after 4 months, and this was a melanoma in situ. Okay, so this is the only way I know to manage this kind of difficult patients with many, many moles. Okay? Not to speak about the special locations. Special locations, for example, vulvar melanosis. This is a very ugly lesion clinically. But nowadays we have a very important way of recognizing vulvar genital melanosis, which is the presence of these parallel lines. And when we see parallel lines, we can be 100% sure that we are on the safe side. Okay? We are very, very specific in this context. Not to speak about facial lesions. In my estimation, facial melanoma is the most difficult melanoma to be diagnosed. And nowadays we have a system, paradoxically, on the face. We shouldn't focus on the malignant criteria as we do for the rest of the body. Usually we look for malignant criteria when we want to recognize melanoma. On the face, we have to focus on the benign features. Okay, because sometimes melanoma is not showing malignant features, but also is not showing benign features. And that's why the method of focusing on benign features is helping. Benign features, here they are. Again, parallel lines, which are pointing to a benign lentigo. Okay, but in a patient like this, there are no benign features, and there are few but very not easily to recognize melanoma-specific criteria, which is mainly the gray color, the presence of gray color. Okay. And number 3, the last reason why I like to use dermoscopy in my daily life. I'm a dermatologist. I'm not only dealing with skin cancer. I'm dealing also with infectious diseases, inflammatory skin conditions. And in the last 20 years, more than 180 different indications in the context of general dermatology were published where dermoscopy was helping in the diagnosis or treatment or monitoring of treatment and so on. This was one of the first indications outside skin cancer that we published a few years ago, quite a few years ago. Of course, I mean, this is a basal cell carcinoma, right? Could it be? Okay, but it's not. And now, of course, it's not easy, but now we know very well that this is a particular kind of infectious disease. This is just scabies. And we can see the mite dermoscopically. Of course, we have to train a little bit our eye, but we can see the mite. And we can see also many other little animals living on our skin. But also in the context of inflammatory skin conditions. For example, come on. This is a case from Emilio, from Greece. This is a psoriasis, right? I mean, no question. Do you agree? Yes. Do you agree? Yes. Do you make a biopsy? No, come on, it's psoriasis. You don't make a biopsy every psoriasis you see. But it's not psoriasis. What is that? You know it now, because we started to understand the face, the dermoscopic morphology of psoriasis, and in this particular case, of lichen ruber-planus. Okay? So this is a lichen ruber-planus. Although, I mean, we know that psoriasis and lichen can be very, very similar from a clinical point of view. Or, okay, this is psoriasis. A tiny lesion, we didn't know what it was, but here you can see what usually psoriasis is looking like in dermoscopy. Of course, I mean, it's not visible from the long distance, but psoriasis is characterized by little red dots, homogeneously distributed within the lesion and scales on the surface. Okay. Or another kind of peculiar morphology. Clinically, it's not easy. This is an 11-year-old boy. There is a white spot on the shoulder. Not so easy to understand if it's a vitiligo or morphea, or I don't know. But what we see dermoscopically, it's just peculiar. It's just specific. It's a combination of white color and comedo-like openings. Can you see the comedos? And this is what we see in lichen sclerosus, extragenital lichen sclerosus. We don't make a biopsy anymore in a case like this. Okay. And more. This is a 65-year-old man. It was during summertime, a rash, a papular rash, rapidly appearing on the trunk. And this is what we can see dermoscopically, and this is becoming very specific. This can only be Grover's disease, okay? It can only be this kind of strange disease. The patient asked me, okay, but what's that? I don't know. Anyway, this is another story. And this is incredible. Or, not to speak about the orange color we can see dermoscopically in granulomatous skin diseases like sarcoidosis, lupus vulgaris, foreign body reaction, and so on. Okay, and also in the context of scalp and their diseases. For example, sometimes it is extremely difficult to understand the difference between Scariga alopecia due to discoid lupus and Scariga alopecia due to lichen planopilaris. And in this case, I mean, it becomes very, very easy, okay? Because the clue here is the presence of these scales around the follicles, around the hair. And this is very, very typical for lichen planopilaris, okay? Or in a case like this, we can think it could be, I don't know, dermatitis, whatever. It's just a solitary lesion. Maybe good clinicians already know what it is. But with dermoscopy, it becomes easier because we see this kind of white follicular areas which are pointing to the diagnosis of discoid lupus. Okay? So white color, it's a very important clue for discoid lupus. This is another lady with a strange macular brown spot on the thigh, and clinically not so easy to understand what it is. But if you look carefully at the periphery, there is this kind of line, and this is the line that the histologists, the histopathologists call cornoid lamella. So this is porokeratosis. Okay. Or other couple of patches, erythematous patches, which are not so easy to identify. Clinically, by the way, dermoscopically, on the right side, we have a clear-cut combination of two clues. These are red spots due to hemorrhage. So this is purpura, because of course, also if you compress, they're not going away. And you have a kind of tiny brownish coloration in the background. So this is pigmented purpuric dermatitis. Okay, and we know that we have many different names to describe this kind of different diseases. Gougerot-Bloom, Majocchi, Schamberg, Lichen aureus. So I don't know why. This is maybe the reason why we have more than 3,000 dermatologic conditions described, you know, because everybody likes to give a name to the same disease, basically. Okay. Well, on the right, we have a completely different disease, much more common, which is characterized by this erythema and peripheral collarette of scales, and this is very typical for pityriasis rosea. Okay, so nowadays, basically, the dermatoscope became our stethoscope, so we cannot really live without it anymore. There is only one more thing that I want to mention to you, which is really also very important. You know, sometimes the comments the patient do when they come to you after having visited another doctor, they're getting completely furious when they say, look, he was even not looking at me. He was even not, he was sitting at his table and he was looking at me from the distance, you know. And this is really getting the patient, let's say, disappointed. With dermoscopy, you cannot do it like this anymore. You have to touch the patient. Of course, you have to touch the patient. Look at this patient, how happy he is, you know. You should get in touch with him. And this is bringing the patient to your side and you on his side. We need this kind of connection with our patients in order that our treatments are functional. So I would like just to close with a very funny thing, an interesting thing that we given by Iris Zalaudek, who is the president of the International Dermoscopy Society. She was asking to a group of clinicians why they eventually loved dermoscopy. And there were very nice, interesting answers to this question. For example, it's a peculiar and continuously evolving science. It's a potential lifesaver. It's the study of the details. It's a bridge between dermatology and pathology. I'm not good in anything else. Quick, simple, safe, and accurate diagnosis. What more can you ask for? It's full of surprises. It's a way of life and thinking. It's the passion and pure love for what you do. It's the love for morphology. It combines usefulness and fun. It's a simple way to explain the pathophysiology of a disease, analytically and aesthetically. Engagement, yeah. It makes us better clinicians and scientists. It can be applied by everybody. It's fast. It's a magical, easy to take medical instruments. Looking at anything through a magnifying glass is fun and exciting. The people and the sense of community. It allowed me to meet a lot of friends. Well, we have to say to this colleague to use a little bit more social medias, yeah? Okay, improves my skills every day, month here. I do not love dermoscopy, but I practice it, of course. What I do love, however, is the dermoscopy people. Yeah, the dermoscopy people are lovely. It fulfills the 3 B's in Spanish language. Bueno, bonito, y barato. Barato, what is barato? I don't know. The community it created, it helps me providing the best care for my patients. In essence, it has greatly contributed in making my work days more enjoyable and less stressful. It's integral part of my life. It allowed me to give better patient care, lecture all over the world, collaborate with others who have become dear and close friends. So yes, I love dermoscopy, what dermoscopy has done for me. I love dermoscopy because it gave me love. Wow. And with this, I thank you for your attention.